So I will be moderating this session. The first speaker is now Dr. Fahim Lala, who will be speaking as already mentioned. Now, please, Dr. Fahim, please start.
Okay, sir, just a second. I am just sharing my presentation.
By the time the next speaker will be Dr. Sufi Taneri from Germany.
Okay. Share screen. You are screen sharing. Can you see my presentation on the screen?
Yes, yes, Dr. Fahim, please continue.
Okay, okay. So, good morning, everybody, and I'm very happy to see you, everyone, and thank you so much for inviting me for this presentation. So, Anjum sir, I am sharing my experience with the magnificent IOL.
Yes, yes, please.
So, I always, tell my colleague and my juniors that you help yourself and your profession by promoting the advanced technology. Whenever you counsel your patient, you explain about everything. Give them all options. When you see the symmetrical cornea, so you promote the advanced technology every time. So bring them to the world of the premium IOLs. We know that now we have the luxury of extended depth of focus lenses, and before the few years back, we were only two options: the monofocal lenses and the multifocal lenses. So now we have this intermediate group, which provide a different kind of vision with a different kind of technology. So we know that this lens has a different kind of aspheric design, and it has a different kind of refractive zone. So it has a different power from center to periphery without any ring. So it gives the vision beyond that can achieve with the optics of monofocal lenses. And it is very good for the intermediate vision, and distance vision is also very much clear. And we know that the depth of focus is always greater than the monofocal lens. The distance corrected intermediate vision is always better than the monofocal, which is not there in case of monofocal. I just go to the point that you see this in the monofocal lenses, the distance vision is very clear, but near and intermediate graph is very much down. And we know that this lens is not going to replace the trifocal and multifocal world, because if you want to give the crisp, clear near vision, when your patient is demanding for the near vision, we have to put trifocals or multifocal lenses. But for the class of the patient, those who are not affording for multifocal and trifocal, you want to mix match, then you see the last graph. It gives the, a good range of vision for distance and intermediate. So the same thing, we have 2 to 3 different kind of brand in the practice. So I have an experience with the iHands and with the Magnificent also. But many lenses I implanted from the Care Group company with the Technics iHands also. So they work on the same platform and I see the same result. There is no difference. So the search for the ideal IOL, I think, ends here. You see this, we have a monofocal and multifocal. In between, we have this no headache IOL. We know that why we call no headache, because it gives the vision beyond 6.6, beyond monofocal, and the good intermediate vision. Like this. So this range, almost patient read very nicely, except the small letters. But if you mix match with the other eye, then your patient will read almost 10.6 binocularly. As I said, the great tool for your patients, those who are not affording for the trifocals and multifocals, so you can mix match it with this. This is also very important point from my side, that we know that we are using different kind of the optical biometers, and many formulas are there. But we know that we always see the very minor error sometime from a toric practice for multifocal, trifocal. Generally, patient adjust it. So this lens is also very important. Because of this ultra high depth of focus, it will adjust this minor biometric error. And we know that all the disadvantages of the multifocal and trifocal lenses, there is no any selection criteria. You can implant with retinal macular pathology, advanced glaucoma, your amblyopic patients, corneal disease, squint, one-eyed patient. Because I have an experience with my one-eyed patient when I generally, I have seen that the patient sees more glare and halos when the patients are, one-eyed patient if you implant multifocal and trifocal lenses. But in the older patient, if they have a demand for the near vision, I always implant multifocal and trifocals. So you see this, the normal light, starbursts and halos. These all phenomena, many of our colleagues, they are more afraid of these things, that if I implant multifocal or trifocal, my patient will complain. But we know that now with the different kind of technology like this, the care group, they have these trifocal lenses. Nobody complains about the glare and halos. But although then also, if somebody has some fears, if they want a peace of mind, then this is the option. You can implant this ultra high depth of focus lenses. So there is no question of glare and halos because it's a one type of advanced monofocal lens. Let me say something about angle alpha. We know that this angle is between the visual axis and the center of eye. So many times we see that our patients are not very happy with the multifocal and trifocal lenses because the angle alpha is very much large. So this you have to check with the eye test machine. I always do that. I always check the angle alpha in my patients. So it should not be more than 0.5 or 0.4. We know that the best is around 0.3 or whatever. So in this type of this scenario also, you can select this lens, go for the beyond monofocal, that's it. Because if your patient is having a large angle alpha, then this will happen because we implant the lens in the center of the eye, the optical axis, center of the capsular bag, and your patient's angle alpha is very large, then visual axis is different. So patient is seeing actually through the ring of the IOL. So he will not get the best vision. Small videos of my two patients. Young male, 44-year-old, symmetrical cornea. You see the uncorrected vision, 6/18 partial nuclear cataract standard. The size of CCC is very important. I always recommend this. It should be perfect circle for your toric, multifocal, any premium lenses. I always use this injection Viscot and sodium hyaluronate. Dr. Arshinov's soft cell technique. Because we know that whatever you implant, your surgery and selection of the patient, everything matters. So it's a combined effort, not only the lens. The care group provide the disposable injectors, you know that. So it is also a one type of luxury. So this patient is the uncorrected vision, distant vision is very good and near almost 10/10. 68-year male. You see the cornea is symmetrical and IOL power is 11.5. This is the magnificent IOL. You see the hole. It is, you will have an easy visco removal because of this. And with the care group, we have a luxury that they can make any power for you. You see the size of CCC, give the good covering to your lenses for toric, for the multifocal, any premium IOL. I always do posterior capsule polishing, everything. So the artistic surgery, your calculations, selection of the patient, everything matters. And then the premium lenses. Thank you so much for your patience hearing. Anjum sir, I cannot hear you.
Dr. Lala, you completed your presentation?
Yes, sir.
So our next speaker is Dr. Sufi Taneri, Germany. but he is not available, so he requested me to present his video. So can I do?
Yes, yes, Dr. Anjum. Yes, Dr. Anjum, continue, please.
Yes.
Hello everybody, this is Supi Tanari speaking from Münster, Germany, and I would like to talk to you about our clinical outcomes with two different phakic IOLs, the IPCL and the ICL. The first phakic IOL implanted in the posterior chamber was presented by Fyodorov in 1986. The most popular phakic IOL today, the Visian implantable collamer lens, or ICL, is based on this original design. The ICL may be regarded as the gold standard for posterior chamber IOLs in phakic eyes because of its proven safety and efficacy. Oftentimes the term ICL is used synonymously with phakic IOL implantation. However, there are at least 3 other models available, one of which is the IPCL. The ICL has been around since 1993, and the current version has a hole in the center which is called Aquaport and has been available since 2012. The range is from +10 to -20 diopters with up to 6 diopters of toricity. In the last year it got the CE mark, but it is not commercially available in a presbyopic version yet. In contrast, the IPCL has been available since 2012 and has a broader range from +15 to -30 diopters with up to 12 diopters of toricity, and it has multiple near adds for presbyopia correction. Both IOLs discussed here have a hole in the center of the optic and some holes in the haptic through which aqueous humor can flow into the anterior chamber. So the design is very similar. And we wanted to compare our results with the IPCL with those that we obtained with the ICL. In terms of surgical behavior, both lenses behave very similarly. The insertion process is absolutely comparable with both IOLs. These are post-operative findings at the slit lamp and on the OCT, where you can see the central hole with a almost two flat vaulting. The IPCL toric has some markings, as you can appreciate in the center of this slide, and the presbyopic version has a three-focal optics with these rings as depicted on the right side. So coming to the actual clinical results, here you can see our 3-month outcomes of those eyes that were targeted for plano. Looking at the uncorrected visual acuity after 3 months, in those eyes with plano target, we found more than 90% within 1 line of corrected visual acuity pre-op with both models. Moreover, a similar number of lines of corrected visual acuity was gained with both IOLs. Regarding spherical equivalent refraction, we observed an excellent correlation with both IOLs up to approximately 20 diopters of myopia. More than 90% were within 1 diopter of the target refraction with both IOL models, and the results were stable up to 1 year follow-up. Similarly, the results for astigmatism correction are equally excellent with both models. Here is a list of all adverse events in the last 10 years. There was a more frequent need for a secondary intervention after IPCL implantation, mostly because of a rotated toric IPCL. Cataract occurred twice after IPCL implantation and 4 times after ICL implantations. However, the ICL implantation have a longer follow-up. The vaulting was perfect in all of these highly myopic eyes, and cataract formation seemed to be age and myopia related rather than caused by these phakic IOLs. Two years after implantation of the IPCL or the ICL, we observed no significant endothelial cell loss. Similarly, both IOLs behaved comparable in terms of intraocular pressure up to 2 years. The pressure spike on the day of surgery is caused by retained viscoelastic material in the eye, which we now avoid with the use of HPMC. And there is no pressure rise up to 2 years on average. So in conclusion, we found equally good visual and refractive outcomes with the IPCL compared to the ICL in high and moderate myopia with and without astigmatism. There is no need for nomogram adjustment when transitioning from the ICL to the IPCL. However, a longer follow-up is warranted to determine stability of results and possible long-term adverse events, especially with the IPCL. Coming to an end, the IPCL is a very promising alternative to the ICL, especially in presbyopes. Thank you so much for your kind attention. Thank you so much for your kind.
Thank you, Dr. Taneri, for your wonderful presentation. I would like to invite Dr. Rohit Shetty, who will be speaking customization with the Squint MRS laser vision correction system, which has a very advanced eye tracking system. It can detect a very small amount of eye movement to give a correct laser on the eye. Dr. Shetty is available.
I think he's not there.
Okay, so now again the next speaker is Dr. Miguel Tuiz from Spain, who will be talking regarding the atomic force microscopy analysis of surface roughness of posterior chamber phakic ion. He is there or not? No.
So I can start, Dr. Mus.
Yeah. Now I would like to invite Dr. Jatinder Bhai, who resides in Lucknow, like me, and we will talking why eye trace is essential tool in achieving protection.
Thank you, Dr. Anju. Thank you so much. Thank you, respected Chairman, Dr. Anil Shrivastava, and my fellow colleagues. And thank you, IOC, for this wonderful arrangement of the session at the IOC 79th, so that we can share something more technologically advanced things which are helping us to achieve bullseye optimization. So let me share my screen, please. Am I visible, Dr. Anjum?
Yes.
Okay.
Yes.
So today I'll be speaking about something, a fantastic equipment which is known as eye tracing. And this is the tool which is now available with us. And why I feel that the eye tracing is an essential tool in achieving perfection. That is something when you want to really hit bull's eye while performing the cataract surgery. Let me all just remind you that eye tracing is an equipment which is not having one parameter. It is having 5 parameters. And it is a 5-in-1 device. And they are wavefront aberrometer, corneal topographer, autorefractor, autokeratometer, and pupillometer. It is having an ocean of knowledge inside it, and you have to dive deep down into it to just extract the exact things this wonderful machine has. And this will take a day-long session, but I will be focusing precisely on just one parameter of eye tracing, that is wavefront aberrometry, and how this has changed the outcome of the premium cataract surgery. And I'm not going to talk about the refractive surgeries. I'm just going to talk about even only the simplest thing, there is a cataract surgery, and how the things have evolved around how the best outcomes can be performed with the eye tracing. So let me just take 2 minutes to give you a brief introduction of what the wavefront is. Wavefront is an aberropia. Just like we had myopia, hyperopia, presbyopia, these were lower order aberrations. We have a term known as aberropia, and it is a refractive error which we have put into this category, which has resulted in decreased quality of vision because of higher order aberrations. Now, what do you exactly mean by this? See, when the light is passing through any medium, whether it is a plane medium or a curved spherical medium, we assume that this medium will not distort the light at all. And the parallel beam of light will just pass smoothly outside, and it will go like a plane wavefront. Similarly, if the light passes through the converging medium, any converging medium, and if that medium is not distorting anything, it is an ideal medium, then the light will just focus on a single point. But there is no ideal medium at all. So once the light travels through any medium, there is a certain amount of distortion of the light, and there is an array of disruption. The light gets defocused, it goes haywire here and there, and it creates different types of foci. So once you pass the light through any medium, we assume that there would have been an ideal wavefront, and now there is an aberrated wavefront, that is a distorted wavefront. And the difference between the ideal wavefront and the aberrated wavefront which you are achieving is known as wavefront error or aberration or aberopia. So we would assume that something would have happened just like an ideal wavefront, but it never happens because no medium is ideal. And that is why we have got aberration. And this is how it looks on the wavefront aberration surface as a 3D map. And this is how it looks as a 2D map, which has got certain green color and certain hot colors on the either side of this thing. This is a 2D representation of the wavefront aberration. And this has been there from ages. And this is how we have recognized now because of the better technology of a machine, which is known as eye tracing. So after giving this brief intro, let me show you what these aberrations are and how do we quantify it. Exactly, there was a very famous physicist who was known as Fritz Zernike, who has done some various polynomial equations, and he has worked out mathematical models of these aberrations. And he then he expressed it as a root mean square value in microns of these Zernike coefficients. And that is how he calibrated these wavefronts, and he named these wavefronts. But let me remind you, these wavefronts are pupil dependent. So the size of pupil is very, very important in human eye when we are going to talk about aberrations or aberopia. And this is how the Zernike said that these are the aberrations of first order, second order, third order, which are by the names of astigmatism, coma, trefoils, pentafoils, which you have already heard of. So I'm going to talk about this, that how they are going to affect our day-to-day practice and how we can achieve best out of this thing. So these are the various wavefronts he talked about. They were second order by the name of astigmatism, third order in the form of coma, trefoil. Then there were again astigmatism, tetrafoils, and pentafoils. Now let us see how it really works. When you talk about eye tracing machine, this wonderful machine does not work on other previous models of Hartmann-Shack model or dynamic skioscopy. So they were the old techniques. This is something which has come out as one of the latest technique, which has been used in various warfares also, first time by the Russia, which was pinpointing at the exact location they wanted to achieve in the light. So this sends 256 the eye in just a time span of less than 1/4 of a second. So these beams go inside the eye, they reach the macula, and the machine automatically calculates the refractions and aberrations, and it projects on our computer. So once these beams go inside and once they land up on macula, so they will give a beautiful representation on the macula, and on the right hand of the screen, you can see at a small, beautiful point spread function where there has been the absolute landing without any major aberration, when you can see that light points are directly focused or pinpoint focus. But once you put these 256 laser points inside and they are erratically placed at the macula, there are higher order aberrations. So this is how the circular pattern shows a haywire representation on the screen. And on the right hand side, on right hand of my screen, you can see that the point spread function is no more a point. It is the array of distorted representation on the screen. And that is how the blurred or a distorted image a patient can see. So this is a machine. This is a technology which shows the doctor exactly what the patient feels like. What is the quality of the vision? Let me remind you, in this era, we are not talking about 6/6 vision, which is the quantity of vision. Even you put your heart inside the surgery, you give a wonderful performance of a cataract surgery with a premium lens, but still the patient may say, Doctor Sahab, mujhko maza nahi aa raha. I am not able to see the things that nicely. There is something, and you don't understand what he's talking about. So that is how this machine tells me how a doctor can feel exactly the patient's problem. So on the left-hand side, you can see that there is a blurred E. There is a blurred E, and on the right side, you can see that there is a sharp E. And here you can see the pupil size is 5 millimeter on the left and right hand side, you can see the pupil size is 2 millimeter. So these higher order aberrations are totally pupillary dependent also. So a patient may have a very good vision in the morning when the pupil size is small. But as the evening occurs, there is a little dilatation in the pupil. There is the overaction of higher order aberrations, and the vision may not be that good. And that is how you can see the blurring of the vision. And that is how the patient is in problem that is known as night myopia or night blur. So The patient's visual problems can be identified by this machine as blurred or a double vision because of coma. It can be in the form of glare and halo caused by spherical aberrations, and it can be a starburst and a comet tails, which are the major cause of dysphotopsias in multifocus caused by trefoil, and you can recognize these problems on eye tracing. That is the beauty of this machine. So how does eye tracing machine aberrometry apparatus helps you and make you deliver under the quality of vision? It does an optical alignment measurement. As Dr. Fahim Lala was talking about, he was talking about the angle alpha and angle kappa, which is the angle alpha is a distance between visual axis and the optical center of the cornea, and angle kappa is a distance between visual axis to the center of the pupil. Now, mind you, these both angles are very, very important once you are trying to implant multifocus, because if they are more than 0.5 millimeters, then the things are going really bad and you are not going to have a good result. So to find out angle alpha and kappa, you have to have this machine, eye tracing, which gives you the exact angle kappa. Now here you can see the angle alpha distance is 0.0098. So this is an ideal, a good alignment with low angle alpha. It's a good candidate for multifocal. Now, supposing you want to put a premium IOL and you have got a large angle alpha and you put it, and then your life becomes haywire. The patient is highly unsatisfied because you have not taken care of this basic measurement, that is angle kappa. Similarly, in this case, you can see an extremely high angle kappa on the right represented. This machine also is user friendly. It delivers the results in the color notions. The red is a danger notion that it says that is more than 0.7. So it is a bad patient for implanting a multifocal lens. It gives you a cautious warning so that you can just decounsel your patient that not to go for a multifocal because your angle alpha is not good. And this is a mid-level or borderline case where you have got 0.394 and you can really go ahead with the surgery. Now, the other thing, this eye tracing aberrometry apparatus helps me is a wonderful thing, which is the calculation of the individual components of the eye so far as aberrations are concerned. Now, what do you really mean by it? This is the machine which tells me that what are the aberrations of the cornea, what are the aberrations of the lens, and what are the aberrations in toto of the entire eyeball once we are subjecting this patient to an eye tracing test. So you make the patient sit on eye tracing machine, you just perform the test, and the light passes first through cornea, then through lens and reaches the macula. So this machine delineates the aberrations which are attributed to the cornea, attributed to the lens, and then in totality. Now, there can be a condition that your cornea is showing high aberrations. It's really showing big aberrations, and the lens is not showing a big aberration. The lens aberrations are very less, but the total of lens and cornea is very high because cornea is showing high aberrations. Now, once you perform a premium surgery, you remove the patient's natural lens. What will happen? The overall high aberrations of the cornea will get highlighted now, and the good vision the patient was enjoying earlier will get deteriorated even you have implanted a best premium IOL, and that is how the patient will feel that something hell has gone bad with me. I paid so much for the surgery and still I don't have good vision. But that is how the surgeon has to know priorly that it is all because of the corneal aberrations, which has now come into action once the natural lens has been removed and a premium lens has been implanted there. So this is a machine which helps in delineating the differences. The other good thing is that it has got a beautiful another function which is not present.
Dr. Why your time is up, and can you finish your talk?
Oh yes, I am just winding up. So this is a machine which gives an important function of known as dysfunction lens index, which tells a green color score, which is a good score that there is less opacity, and the red color score which tells us to avoid the surgery. So this machine is in totality such a beautiful machine which makes you understand. And the best part is that this machine also helps you in identifying the limbal vessels as a marker, which are better than the ink markers to perform a toric surgery. This machine is so beautiful that the technology here helps you to take a decision to eliminate the problem once the surgery has been performed and the results are not coming. So you can know where the problem has gone wrong, where the things have gone wrong. You can recalculate your toric results, how much off center you are from the toricity, how much lens you have to rotate so that you can just come back to the normal and give patient a satisfactory result once you reoperate upon it. So this is a machine that gives you the total cross check that how much rotation you have to perform over once the surgery is, and how much you are off the track so that you can go and give a good result. And one last thing before I finalize my talk, it is a machine which recognizes the lens tilt, which is a notorious problem of dysphotopsia. This is a machine which gives a central green axis and the colored presentation of two colors on the either side of the central green distinct. And this is a very good indication that your lens is having a tilt, and that is why the patient is in problem. So you have to recorrect it. Thank you so much. Thanks a lot.
Thank you, Dr. Wahi, for such a wonderful presentation on eye tracing. So I would like to invite our next speaker, Dr. Rohit Shetty from Narayana, Netala, Bangalore. We will be talking regarding the customization with Squint MRI Advanced Vision Laser Correction System, which has a very advanced eye tracking, which can correct the slightest movement of eye using laser correction. So please, Dr. Rohit Shetty is there.
Not here.
Okay. So I would like to invite Dr. Bhagyashree H. Deshmukh talking about triphobic IOL.
Yes.
Dr. Bhagyashree.
Hello, sir. Good morning.
Yes.
So, good morning, everyone. My topic today is why trifocal IOLs and my experience with triphobic HD. So, let me share my screen. So, excuse me. So I hope everybody can see the screen.
Visible.
Yeah, thank you.
Yes, visible.
Thank you. So before I share my experience, I would like to take you to a briefly through basics of multifocal IOLs. So essentially, multifocal optics is a trade-off between an improved range of vision and visual artifacts such as glare and halos. So diffractive optics has largely overtaken the market since it has reduced the halos and glare drastically, and apodization has further reduced this unwanted photic phenomena. So diffractive optics basically takes the wave nature of light into consideration. Waves generally have the ability to interfere with each other. So basically in diffractive IOL, there is an aspheric lens and a structure with zigzag sharp edges, which is placed on the lens, which is called kinoform. And this kinoform intentionally induces diffraction so that the waves exiting the lens will have constructive and destructive interference. While constructive interference gives multiple foci for distance and near vision, and destructive interference causes loss of contrast. This picture here on the left-hand side represents schematically light diffracting through a diffractive IOL. So the diffractive pattern, that is how much light energy we will go for distance and how much for near, is mainly governed by the height of the steps. Some percentage of light may not be diffracted at all. That is called zero order diffraction, which is for distance vision. In this pattern of kinoform, around 40% of light is for distance. And some light, here around 40%, is diffracted to the near foci called first order diffraction. And remaining 20% is diffracted into higher order, which causes halos. While on the right-hand side, the width of the steps of kinoform determines the addition power of the lens. Well, the smaller the width of the steps, more the addition power in the lens, and larger the width, lesser the addition power. For example, over here, in this diffractive structure, it has smaller width on the first structure, so it has a higher addition power, that is +3, and the second kinoform has more width of steps compared to previous one, so it has +1.75 diopters of addition power. So basically, in trifocal IOLs, combination of two diffractive surfaces, one for distance and near, and other for distance and intermediate. The combination of these two makes a trifocal IOL. And in triphobic HD, there is combination of plus 3.5 and plus 1.8 diopter kinoforms. And there is decreasing step height and increasing angulation from center to periphery. It ensures good light distribution in both mesopic and photopic pupil, which is commonly known as apodization. All right, so this is very important. So as we have understood that trifocal is combination of two diffractive structure. In first structure, as we can see here, zero order goes for distance, first order for near, and second order, which is multiple of first order, is lost in first diffractive structure. The light, that amount of light is lost. But in second structure on the right hand side, again zero order for distance. The first order is for intermediate plus 7.5, and the second order plus 3.5, which is for near vision. So actually this recruitment of second order for near vision makes utilization of maximum light energy possible. So that's why there is increased contrast in trifocal compared to bifocal lenses. And this was the physics part of it. And before I go on with my experience, I would like to tell you the story of old couple who came to us for cataract surgery, and they were well aware that there are lenses which makes you glasses free after cataract surgery. So initially my cataract counselor used to advise all trifocals to computer users and bifocals to all housewives and non-working people. So accordingly, they underwent cataract surgery. And after operation, this lady comes to me complaining that this gentleman, her husband, who has implantation of trifocal IOL, could see the dirt in vegetables while cleaning them, and she could not. So everyone needs intermediate vision, not only computer users. So my experience here, what we did was we put out data of 44 eyes of 26 patients with triphobic implantation. Average age was 58, and average pre-op uncorrected vision was 6/60, and base corrected vision was 6/18. All of them underwent detailed preoperative workup. At our center, all premium cataract patients undergo topography, as just the previous talk explained it. We look at higher order abrasion, which should not be more than 0.3 for any type of multifocal implantation. Spherical abrasion should not be less than 0.35. Angle kappa and alpha were looked into, and it's not a very good idea to advise patient with more than 0.5 millimeter of angle or angle alpha or kappa for multifocal implantation. And the post-op result, the average post-operative uncorrected vision for distance was 6/6 parts. For near at 35 centimeter, it was an N6, and for intermediate at 70 centimeter, it was N8. So if you look at the defocus curve of triphobic HD, it shows 3 humps for distance, intermediate, and near respectively. The dip which we get in bifocal lenses, or now commonly known as multifocal, for intermediate range is definitely gone. So to conclude, I would say that trifocal lenses gives excellent distance and near vision if your biometry and surgical technique is perfect. They give improved intermediate vision compared to traditional bifocals, and there's very minimal contrast reduction. Photic phenomena like glare and halos are there, but they are not bothersome, so much so that we can even prescribe trifocal lenses to young active males as well. Since the last few years, we have started shifting to our practice from bifocals and from bifocals to trifocals, and that has definitely led to happier patients and definitely happier me. So I think that's my last slide. Thank you very much.
Thank you, Dr. Bhagyashree, for giving a wonderful insight into trifocal IOL. And I would like to invite the next speaker, Dr. Maxwell Toes from Spain, will be talking regarding the atomic force microscopy analysis of the surface roughness of posterior chamber phakic IOLs.
Thank you. Can you hear me?
Yeah, please. Please
Okay.
continue.
Let me share my screen. How do I do this? How do I do to share my screen? I use so many softwares that I don't know how to share my screen.
Go to the green button, share screen at the bottom. First of all, go to the desktop. Just highlight your presentation.
Yes.
Make it into a this thing full screen, that presentation, and then come back to this Zoom platform once again.
So full screen.
Now come back to share platform, this Zoom platform once again.
I come back to Zoom.
Yeah. Now you can see the green icon share screen at the bottom of
Yeah.
Just click that button first.
Yeah.
Now you can see the presentation which you had already highlighted. Yes. Okay, we can see you.
Yes.
Thank you, Tom. Thank you, Dr. Wahi.
You're welcome.
Thank you very much.
Muchas gracias. Muchas gracias.
De nada. Well, this is my pleasure to participate in this symposium, and thank you very much, the organizers, for the invitation. My topic will be the atomic force microscopy analysis of the surface roughness of posterior chamber phakic IOLs. These are my financial disclosures. The surface roughness is critical for the optical performance of any lens. Light scatter depends on the roughness of the surface of the lens. The amount of roughness varies significantly in different IOL models, and it seems to depend mainly on the degree of polishing of the IOL surface. In addition, IOLs with higher roughness show more friction with adjacent ocular tissues, so lower rotation within the capsular bag, for instance. As you can see here, when light hits a rough surface, you find what is called diffuse reflection, diffuse refraction. That means light scatter is being created, so that means haze, and this is not good for the optical quality of the system. On the other hand, if the surface is absolutely flat, then you will have specular refraction and refraction, and the Snell's law is going to be followed. So this is the perfect situation for any lens. Atomic force microscopy is a technique that has a resolution of less than 0.1 nanometers in the vertical axis, is useful for the analysis of surface roughness of any material, such as the cornea, intraocular lenses, etc. And here you have an example of a 3D representation of two different IOLs, the one on the left with 0.5 nanometers mean roughness, and the one on the right with 4.1 nanometers. And here you see both IOLs, the same IOLs inside the eye 24 hours after surgery. The one in the left, you simply cannot see the anterior surface because there is no light scatter. And the one on the right, you can see where the lens begins because you see the interface because there is light scattered there. We designed the following work, which was published a couple of years ago with Narayana and other colleagues. So we decided to analyze the very last models of the main, IOL manufacturers of hydrophobic pseudophakic IOLs. As you can see here, the roughness of the surface ranges from 0.5 till slightly more than 4 nanometers. And please keep in mind these figures. These IOLs were put in a special artificial anterior chamber, so the haze intensity of the surface could be measuring the pixel haze intensity. And as you can see, there's a huge difference in the pixel haze intensity measured by a photograph. If we compare the amount of roughness with the pixel haze intensity, we found that there is a very close correlation with an S-square of 0.88, close to 0.9. That means that all the light scatter coming from the surface of an IOL just implanted, so no right after implantation is due to the surface roughness. In addition to this, it has been demonstrated that the higher the roughness, the less the polishing, the higher the roughness, the more frictional coefficient, the more friction this IOL has with adjacent tissues. For instance, in trifocal toric IOLs, this is important because the rotational stability is increased. We decided to study and to compare the two models of posterior chamber phakic IOLs, the IPCL versus the ICL. And this work has been already accepted for publication. It will be open access in BMC ophthalmology. So those interested may take a look. The roughness was evaluated with JPK NanoWizard atomic force microscopy in the contact mode. The surface measurements were made on 7 different areas of the central optical zone of the anterior surface of the IOL, analyzing an area of 10 × 10 microns. All measurements were made with the IOLs kept in water, in midi-Q, let's say deionized water, and 4 IOLs were analyzed, 2 units of IPCL 2.0 from K group and 2 units of ICL V5 Evo Plus Star, the last version of the ICL. In all cases, dioptric power was -12 diopters. Here you have the roughness values. As you can see, both IPCLs have statistically significant and clinically relevant. You know, the magnitude is quite high roughness than the ICL lenses, and the difference was statistically significant. As you can see, the IPCL has more or less the roughness that modern hydrophobic pseudophakic IOLs have, and the ICL is clearly has more roughness than the pseudophakic IOLs I showed you before. Here you have an example, a 3D picture of the how the IPCL looks under the atomic form microscopy, and here you have a picture of the ICL. Clearly a difference in terms of roughness. As we said before, these may have relevance in terms of light scatter at the surface, and also because of the friction of the IOL with adjacent tissues. We have to consider that the posterior chamber ICLs are in close contact with both the crystalline lens and the iris. So probably the less the friction you have, the better for the eye in the long term. Is this a problem? Well, it may be, because it's been reported that 10 years after implantation of the previous version of the ICL, approximately 18 cases at 10 years 13% of the eyes developed ocular hypertension that requires topical therapy 10 years after implantation, and a significant proportion of study eyes showed pigmentation in the angle and ocular hypertension. With the last model, the Evo ICL, as you can see, with just 5 years follow-up, because no studies with longer follow-up than these, you have around 10% of cases with a significant increase in the intraocular pressure. So, conclusions. There is a need for a constant improvement of the IOL design and materials, and it's clear that the polishing of the surface, the less the roughness you have, the better the quality of the manufacturing process in terms of polishing. The IOL surface roughness is critical for the light scatter at the IOL surface. That means optical quality. The pigment dispersion and ocular hypertension is still a concern after posterior chamber phakic IOL implantation because of the iris IOL rubbing in the long term. And it's plausible that the smoother the IOL surface, the better, because less friction is produced. And the IPCL V2.0 has a statistically significant smoother anterior surface than the ICL V5. And I thank you very much for your kind attention. Huh?
You have to stop share your screen at the top now.
Yes, yes, I did. Well, I have to say, I couldn't see the timer during my presentation.
Yeah, it was there. It was there on the right-hand side.
No, I didn't see it. So.
Dr. Meghal, you have to stop share your screen now. Dr. Anjum sir, you are muted, yes. Yeah.
Now I invite Dr. Rohit Shetty to please join. If he's here, please join to talk about the. He's here, Dr. Rohit.
No, sir, he's not here.
So Dr. Ramamurthy, D. Ramamurthy is here.
Dr. D. Ramamurthy also is not here.
So we have no speaker left for now. So should we wait for 1-2 minutes for Dr. and we start taking the questions in between regarding the presentation already being done? If anyone can ask a question from the co-speaker in between.
My question to Dr. Jatinder, sir. Hello.
Yes, we can hear you. Please continue.
Do you hear me? My question to Dr. Jatinder, sir, Anjum, sir, that when we examine the patient on the eye test machine, do you think that when the patient is not cooperative, if he's not opening his eyes fully, and we find the different kind of the results, what is his recommendation for this? Sometimes we see the different results when we check the patient 2 times, 3 times, when we take the multiple readings on eye trace.
Dr. Fahim, I could not hear you. Please, can you repeat?
Sir, I asked you that when we see our patient on the eye trace, right? So we know that these are the machines, they give the reading, give the results, depend upon the patient's cooperation. I mean, how you perform the test and whether eyes are fully open or not.
Yeah.
Sometimes leads and eyelashes are coming in between. I have seen when I check my patient, sometimes angle alpha coming more than 0.5. And when I check it 2 to 3 times, it comes to a little bit normal range. So what is your point in that? How to get the best?
The best thing is just make the patient chin and head alignment perfectly well centered. His position should be very comfortable. If his chin and head are well aligned, and ask him to look at distance while focusing, you will get a perfect result. You don't have to worry about that. The moment the head tilt, the things goes.
Dr. Anjum,
Yes.
Dr. Rohit Shetty is also come.
Yes. And I would like to add one more point, Dr. Lala. If the patient is having discomfort, just give 1% CMC to that patient.
All right.
Tell him to sit for 2 minutes, then you can do the examination again. Okay.
Perfectly. Thank you, sir.
Now, Dr. Rohit Shetty, I came to know Dr. Rohit Shetty has joined. So I would like to invite Dr. Rohit Shetty to continue, give a talk regarding the squint system, MRI system, which is a very advanced eye tracker. We can say it's a very slightest movement of eye. So Dr. Rohit Shetty, please join.
Thank you, sir. Thank you. And can you see my presentation?
Yes.
Yes. I can see your name now. Please do the screen share.
Oh, it's not screen share. So 1 minute. Let me just 1 minute. take a few seconds with this iPad. Just bear with me. Can you hear me?
Wonderful, wonderful. Now your presentation is also on the screen, and now you please continue.
And my talk today is customization with Twin MRS. Thanks the AIOS chairman and the company at the IOCare and were distributors of Schwind for giving me this opportunity. These are my financial interests. When you need a customization, you need it for when you're planning a LASIK, your PRK, and keratoconus. And when you look at patients who are not happy with the previous surgery, the customization. So in the interest of time, I'm not going too deep into all the way it's been done, but it's always about customization between your total wavefront guided treatment and also looking at a corneal customization. So one of the best part of the Schwind, which I really enjoy, is this platform. I call it as the thinking machine. It's a perfect workhorse. At one go, you look at, you can play with these very, very beautiful software. You look at this, you click on anything. This is the ocular wavefront. This is your corneal wavefront. And this is aberration-free treatments. Most of the time for patients who are perfectly healthy, we only look at this. But we look at this when we are having an aberrated cornea or an optical imaging which is not healthy. It gives you plenty of things for you to look at. There's an asymmetric offset based on your X and Y coordinates. If it's really bad, you can really off this. It looks at the center of the pupil, or it looks at where your X and Y coordinates are. This is a beauty of customization. Not just one, you have virtually everything is customization. So I have named it as a thinking machine. It helps me to think. It tells me between what ablations I'm getting. I can choose whatever is the least amount of ablation, and then I can treat the patient. For example, this is AF, the aberration free, and CW. Look at this. It looks at how the coma has been corrected and how it's going to change the correction. That means it is taking in here, it is not looking at all the aberration. Here it's taking in the coma. And if this is a patient who has a 0.64 diopters of coma, I would prefer the CW. And I would not want this because it's not taking care too much of coma treatment. That means it is giving you a perfect quality of vision, even in a healthy patient. This is exactly what you call it as a contura. It's exactly what you call it as different names you get from different companies. When I plan a PRK, again, the same thing happens. But what is important for me is this thing, which none of the machine can give you, your central zone, peripheral zone. That is something which is very exciting because it tells you exactly which part of the cornea. For example, if I have a cornea like this, the central epithelium is, say, 57, the peripheral is 50, I can choose it, I can use it. And that is what makes it so beautiful. And again, this is a treatment summary, which tells me whether I should use an AF or I should use a CW, which corrects my coma, trefoil, spherical aberrations, and everything. Look at this same value and look at this. That's what makes it different. The real power of it comes when I go into the keratoconus. And this is what been published by us about the topography treatment. It gives you a better contact lens fit, aberrations, and it changes the complete profiling. This is, I've been using it for the last 4 years now, and I proudly say that we do close to around maybe around 1,500, 2,000 sometimes in a good month of cross-linking, because we get a lot of patients. It's reduced now. 99% of my cross-linkings are done with laser-based because I believe that giving a proper lasers helps in regularizing the cornea and it gives you the best outcome. That can only be possible if I know how to use the machine. This is a track which we use it ourselves. I'll explain about it. The CW is from your cirrus, and OW, the optical wavefront from the pyramids. I should have brought it 5 years back when I bought the machine. I was late, and I really feel that this changed the way the customization has happened. If somebody is buying this machine, I have no financial interest. Vipin doesn't give me anything, but trust me, even if you pay you more, this is what is going to change your practice. And I'll tell you why. Because I don't want to go into the ocular wavefront and the corneal wavefront optics at this point of time. It's just that, ocular wavefront looks at the entire cornea, from the tear film to your lens, and then you treat it. The corneal wavefront is your anterior corneal. Most of the time is anterior corneas. Maybe a small amount it comes from the posterior cornea. Why it's important is because when you look at a different profile, the corneal wavefront, sometimes you have a huge amount of cornea being treated on the coma. And you see that when you use the same patient, you can see that 27 microns was being burned. And you can see it's just 9 microns is burned on ocular wavefront. It saves sometimes around 70% less tissue when you're operating on an aberrated eye. Why is it? Because half of this whole thing is reduced by the lens. You don't need to treat everything just because the cornea has a problem. Let's understand one thing very clearly. Just because there is a problem on the corneal plane, let's not jump and treat everything on the corneal plane, because if this is your cornea and this is your lens, if there is a coma here, the corneal wavefront assumes that treat it, burn it, and knock it off. But an ocular wavefront, what it tells you is the laser light is there, but the lens is making it normal. And it treats only thing which is irregular here after it passes. And that is what is being treated, unlike the corneal wavefront here, which assumes that everything is coming from the cornea and you treat everything. Look at the ablation profiles. It is just 9 microns compared to 24 out there. Let's look at the case scenarios. Corneal wavefront, look at how much it's burning, 81 microns. And look at how much it's burning. What happens is you're looking at around 41 microns. Look at look at this area out here. Look at this area out here, which is so red and so increased in this. And look at this here. I'm keeping everything as 0. So what I'm trying to say is there is a huge change in how the ablation pattern is, because here it looks at the whole thing and what is actually going out after the lens has already made it irregular. Here, everything happens at this plane, and this is what is burning. And here, this is the pattern, what comes here. That's why the ablation depth is very low, and that's why it takes in very less tissues. And look here, this is a central ablation of 69 microns, and you have 7 microns. So sorry, 19 microns here. This is with the epithelium. It's 7 microns. Again, the same concept of what it's doing. And you can see that sometimes you have an ocular wavefront aberration, which is completely different. That's because it takes into the account of the lens also. And you can see this difference of around 9 microns here. Again, the same thing. And this is where we choose. And the more examples of this, and you can see that sometimes both are same. That's because your lens and the cornea are in sync. So 5 microns and 5 microns are good. So you don't need to worry about it. And this is the planning, which I want to skip. And you can see the kind of results we're getting is phenomenal. And this is from the CW. This is again a phenomenal results. You can see the change. You can see how the refractive error was. And look at this. And this also is beautiful as far as the post-op outcomes are concerned. We designed one more thing for patients who are not comfortable, where they're not much of a corneal thickness. We could do a small PTK of around 10 microns above the epithelium. If epithelium is 45, add 10 to it, it becomes 55 microns. And what happens is it just shaves off that area only. And this is the only machine on earth where you can decenter the laser and with the cyclotorsion compensation so that you end up exactly in the same position. And you can see that this is how you can treat, and this is published now in JRS, and you can see exactly the same zone, and you can get extremely good results. And this is a paper which is published fantastic. You can look at 37 to 40%. And how much are we burning? Just 10 microns more. And even if I'm not doing any laser procedures, I'm just doing a cross-linking, I still stick to it because it gives me fantastic results. You're looking at more than 50% of it gaining 1 or 2 lines more. And this is what, if you topo guided, it may gain increase, but it also burns more. Here you may have a smaller gain, but it hardly gains anything, and it gives you a good amount of stabilization. And this is a zone enlargement, and this simple example of a person who had a LASIK, now he wants cataract surgery, and you can see that we do a topo-guided PR case. And in this patient's elderly patient, I do a CW platform because OW will have a lens-induced changes, which I don't want to. So you can keep all these people as CW, and you can see that this is an ablation profile for them. Again, there's a minimized depth where it only picks up one in green. Is all about how it picks up the aberration. When you do the minimized depth, this is what a thinking machine would do. It picks up all the beautiful things, and you can see that it's only all that one gray. It is not going to treat. Only in the greens are the ones it's going to treat. What does it do? It saves the tissue. It reduces the tissue by around 20%, 30% sometimes. And that is what you need to use in your machine. And that is where it's completely, no other machine can do all this, because other machine assumes you to just feed in and treat. But here it makes you to think, and you should keep thinking. And look at this. The depth before it was 53, and I've reduced 10 microns by removing only things which I don't want to treat. And this is what is very important. And you can see how this irregular zone has completely become regular. And, and I've changed it by around 20 microns, but that should be okay because the patient quality of vision is good. Just pause for a few seconds here. These are all the videos we have made. You can take this, QR code and start looking at all the videos, how you can plan it. I thank all the panel again, and also the Schwind Amaris team for giving me this opportunity. Thank you.
Thank you for a wonderful talk by Dr. Rohit Shetty regarding the customization of the Schwind Amaris system, which is very advanced machine and giving very good results. The research is still continuing and more to come, I think. So I would like to invite Dr. Anil Srivastava if he has any question to ask from Dr. Rohit.
It's all right.
Okay, anyone who want to ask questions from Dr. Rohit, please ask. Can you hear me?
It's muted, I guess.
Yes, it is audible.
So anyone who want to ask questions from Dr. Rohit, please ask. He has very great knowledge regarding the excimer laser system, and he will be clearing most of the doubts. Please ask him. Any from the audience?
I think everybody is clear. Thank you, sir. Thank you. Thanks a lot. And thanks the AIOC team for this opportunity. Thank you.
Thank you. Thank you again, Dr. Rohit, for the
Thank you all for joining in. And Rohit sir, thank you.
So, one speaker left, Dr. D. Ramamurthy. Is he here?
Sir, Ramamurthy sir is not here. He's in another session right now.
Okay, so we finished all our speakers. Yes. So we would like to end our session. Kind permission of Dr. Anil, our chairman.
Yes, Dr. Ramja. We can conclude it.
So, thank you all.
I thank you all for being with us for this wonderful information. All the talks were brilliant. Thank you. Thank you so much, sir. Thank you so much, ma'am, for joining in with us.
Thank you so much.
Thanks to all.
Thank you.